Thank you to the organizers for allowing me to speak on the NCCN guidelines for treatment of localized prostate cancer. Here are my disclosures. Today, I'll be discussing the NCCN practice guidelines for prostate cancer that were published in May of this year. Approximately 270,000 men will be diagnosed with prostate cancer in 2022. Fortunately, the majority are diagnosed with localized disease. However, as you can see, up to 20% of men are diagnosed with either regional or distant disease. This has implications on survival, as men with localized disease can enjoy 100% 5-year relative survival. However, with distant disease, it drops all the way to 30%. Risk stratification, according to NCCN guidelines, are as follows. For very low-risk disease, men have to have all of the following: normal prostate exam, Gleason grade group 1, PSA of less than 10, fewer than 3 positive biopsies with none more than 50% positive, and a PSA density of less than 0.15. For these patients, you should also consider confirmatory multiparametric biopsy with or without the biopsy if MRI is not performed. And they should undergo confirmatory biopsy within 1 to 2 years of the initial one. Low-risk disease has similar pathologic features, except for the number of cores, which can be more than 3, and no need for PSA density testing. Again, confirmatory multiparametric MRI can be performed in these patients, as well as confirmatory biopsy within 1 to 2 years. For intermediate risk disease, the patients cannot have high risk or very high risk features and have one or more intermediate risk factors, including clinical T2B or T2C, grade group 2 or 3, and a PSA of 10 to 20. This is broken down to favorable versus unfavorable disease. For favorable, they can have one intermediate risk factor, Gleason grade group 1 or 2, and less than 50% cores positive. For unfavorable, they have 2 to 3 risk factors, grade group 3 disease, or more than 50% biopsy cores positive. For men with unfavorable intermediate risk disease, we will consider bone and soft tissue imaging, which I'll discuss on the next slide. For men with high risk disease, they can have at least risk feature, including T3A disease or Gleason grade group 4 or 5, or a PSA of greater than 20. For very high-risk disease, they can have multiple high-risk features, higher clinical staging, primary Gleason pattern 5, or more than 4 cores with either grade group 4 or 5. In these men, they should also get bone and soft tissue imaging, which can be achieved with either technetium-99 bone scan and CT or MRI of the abdomen and pelvis. Multiparametric MRI is preferred over CT for pelvic imaging. PSMA PET, CT, or MRI is an acceptable first-line modality, and the panel did recommend that PSMA PET, CT, or MRI can be performed initially without necessarily having to get a negative or equivocal CT or bone scan. Here's the summary of the initial treatments for localized disease. For very low risk and low risk disease, active surveillance is the preferred modality. You can perform EBRT and or brachytherapy for patients with expected survival of greater than 20 years, similarly for radical prostatectomy. For patients with low survival expectation, particularly less than 10 years, you can perform observation. For favorable intermediate risk disease, you can perform active surveillance in select patients. However, they should receive curative therapy in the form of either EBRT or brachytherapy, particularly if survival is lower, or you can perform surgery. For patients with 5 to 10 year survival, you can perform observation. For unfavorable intermediate risk disease, active surveillance is no longer a preferred therapy. They should receive EBRT with 4 to 6 months of androgen deprivation, or radical prostatectomy with pelvic lymph node dissection if the risk of lymph node metastasis is at least 2%. Again, observation can be performed for men with low survival. For high and very high risk disease, multimodality therapy is preferred. This can be done with external beam radiation with 1.5 to 3 years of androgen deprivation as tolerated. And for very high risk disease, you can consider docetaxel. Additionally, you can perform EBRT with brachytherapy and ADT again for 1.5 to 3 years. In performing surgery, radical prostatectomy should be performed with extended pelvic lymph node dissection. For men with this very high risk disease, you can perform observation only if they are asymptomatic with low risk of survival. You can also do ADT alone or EBRT for local control. Some other changes in the 2022 guidelines: gallium PSMA or fluoride 18 PSMA PET CT or PET MRI can be considered for bone and soft tissue imaging. Again, this can be used as an initial imaging. The addition of EBRT and ADT, abiraterone acetate, can be used for the high and very high risk groups. The panel recommends the use of nomograms as well as the consideration of various demographic and clinical factors, including the Decipher molecular assay to individualize patient treatment decision-making. Decipher scores greater than 0.6 should be considered for the addition of ADT when EBRT alone window has been missed. In summary, active surveillance is the preferred management for men with very low risk and low risk disease. You can use for men with favorable intermediate risk disease in appropriately selected men. Black men may have increased risk of progression on active surveillance, but a non-significant difference in overall and prostate cancer specific survival. This, again, is in an equal access setting. All treatment modalities do have specific risks, and there are various nomograms available to employ a risk-adapted strategy. Optimal patient selection paired with shared decision-making regarding treatment leads to the best outcomes. Thank you very much, and enjoy the remainder of the meeting.